foam sclerotherapy. Sclerotherapy has Dr. Dietrich has been doing sclerotherapy for what, 30, 40 years now. Anyhow, but certain things changed in the last 10 years. So I'm just going to touch base to see if it's really the old technique being done by different people, or is it something really new, an old wine in a new bottle. But we think with a foam, wine actually really becomes almost like a bubbly in the champagne. Ultrasound-guided foam sclerotherapy. When you inject a regular sclerotherapy solution, you really don't know where it's going because it's liquid and there's no contrast in terms of echogenicity. So with ultrasound, you can't see. You can see the needle, but you can't see where the fluid is going. However, when you make a foam, which is basically a froth, there's a lot of minute air bubbles in it, so you can really see the contrast as the ultrasound, as the foam goes into the blood vessel. It's very simple. It's affordable because it's relatively inexpensive. Of course, once FDA came into play, a solution that used to be compounded for about $10 has become $200 now because of the process of getting it approved. But it still is inexpensive. It's safe, and we'll talk about the safety a little bit. I think I saw Bob talking something about PFO, so I think that has a role in this. And of course, it's very efficient. And the good thing about it is, if it doesn't work all the time, you can very easily repeat it. So an ideal sclerosing agent must ensure appropriate concentration of the agent with the integral contact of the entire venous wall. Dr. George Fagan in the 50s was actually a real proponent of how to do this. And what he did was he put the needles into the vein in a depending position, like how Dr. Dietrich used to when I was a fellow here a few years ago. And then elevate the leg so that the blood is all evacuated, and then inject it, and immediately put compression on top of it so that the sclerosing solution would stay in contact with the blood vessel wall, and thereby irritating the intima and killing it. Really cumbersome, and it took a lot of time. But in contrast, what's happened is the liquid sclerosing agent gets washed away with the blood, and quickly, and with the vein diameter over 3 millimeters, even more difficult. So when you inject the foam, it has the advantage of filling the vein and staying longer and causing spasm. It's like if you pour a can of Coke in a glass, you get all this froth on top, and it stays a while for it to settle down. And the same thing happens because of surface tension, it stays longer. So what we used to do was we used to inject some air to clear the vein first of the blood, and then inject the solution, thereby the dilutional factor was gone. When somebody comes up with a new idea, you wonder why you didn't do it earlier. But Cabrera in Italy and Tassari, together they came up with this idea of foaming a sclerosing solution. Basically, they mixed a portion of solution with a portion of air or carbon dioxide, and then made the froth. But of course, you can't use saline and hypertonic solution to make a sclerosing agent. It has to be a detergent, such as soda-decoll or polydocanol or sodium morowate, to really make the solution. The way we use it is actually, I use 3 parts of carbon dioxide, 1 part of air. We used to use the air in the past, but there's another non-FDA approved off-label use, and therefore you want to make it as safe as possible. And CO2 gets absorbed much faster, and it's also, we have a lot of experience injecting CO2 into the vascular system for contrast angiogram. So this is how I mix it. So it's a little stopcock that's come in, instead of 3-way, it's just a 2-way. So you can agitate it between your hands, and the foam stays for about a minute. Sometimes multiple repeated treatment may be necessary, and therefore research should be assessed in a lifelong point of view rather than just a vein that was treated. I'm going to show a few cases of how it's done. Now, when you see the leg of this person, you'll really be amazed. He's got what's called as a triple Trenari syndrome, and nobody wants to really operate. It's a bloody mess. But here, what I'm going to do is just cannulate these veins with a little 27 gauge butterfly. And then under ultrasound guidance, you can see the contrast nicely. This is the vein, and this is the foam getting into it. And so you can see the shadow that's coming out. And this vein is getting filled, and this is yet to fill. And of course, this is what the leg looks like. You have multiple ulcerations. Now, as you can see, even here I'm doing it on a dependent position. You want the head down because the foam, like air, will race to the top. It'll come towards the foot. And also it will go only to the bad veins. It won't go to a good vein because the valves will stop the foam from going up. Of course, wrap it up and then put the stockings on immediately. You really don't have to have the combination, what we did with the. Now here I'm doing a case of a small saphenous vein. I enter the vein with a little angiocant, and you can see the little video that's showing how the foam has gone into the. Now I'm puncturing the little blood vessel, and you can see the foam coming out. You see that nicely, like a beautiful curtain that's coming out. I can follow this all the way up to just distal to the junction of the popliteal vein, and it's kind of tricky. And then we put a little bit of compression with our probe itself, and thereby we're thinking that we're preventing it from going into the heart. But of course, I did a few cases where I did echo at the same time as we're injecting into a small vein. Within minutes, the foam is all over the body. It's going across the heart and everything. So it's not a major problem if it's small quantity. Now you can see how the foam is completely occluded the vein, and you can see the pulse style thing because I'm putting compression with my probe. Now I've released it, and you can see the foam just stopping right there. And the vein has gone into complete spasm. Now, I'm going to show you my technique of how to take care of the great saphenous vein. Of course, this is not a great saphenous vein, but it's just to make you all wake up this morning. What should I do? There's a video. Oh, there you go. So this is a very elderly lady. I thought even endovenous ablation with the laser is probably a relatively contraindication. So here I'm puncturing the vein like I always do for axis. This is a great saphenous vein. I like to do it in a transverse position. Got into the vein, and I'm putting a little guide wire, and then I'll exchange it to a longer sheet that'll go all the way up to the saphenofemoral junction. This is my guide wire coming, and I'm going to have the sheet following that. This is the superficial epigastric vein, so that's your landmark. And this is the incompetent valve that you can see nicely that's flopping around there. I did this case live for one of the congresses. I brought it back because it's almost 3 or 4 years now, and the lady has done very well. But of course, she's very elderly, and I don't have the most recent ultrasound. So it's very similar to how I would do the laser. So I've got the sheet all the way up here. You can see the sheet right up here. The guide wire is coming out. You can see the J disappearing, so you know exactly where you are. That's the end of the sheet. Now I got the leg elevated, and of course this is my most expensive piece of. I guess you all know it's a toilet paper holder, and works very well. And Dr. Dietrich was a particular boot that we used to have for. It's one of the elbow pads from the old football. Anyhow, injecting this little foam, as you can see, now you can see the foam coming in through the sheet. You got to be very careful. You just can't inject it too fast because this is a lethal dose of air and carbon dioxide coming out. But as you can see the foam coming out, and as the foam comes out, I slowly start to withdraw my sheet. So I'm not putting any balloon catheter or anything. A lot of research has been done. The best thing is to keep the leg elevated and do it like this. And you can see immediately the vein goes into spasm because it's an irritant. I'm using sotradecol here. That's the one that was approved at the time. A few months ago, polydopamol also has been approved. Now you can see as I'm withdrawing it, you can see like a curtain falling in with the